Thank you very much, Andrew. So we're going to start with stepping backwards in time. And so Dr. Perk has asked a few questions and a strong advocate for the use of digoxin. The last 25 years, digoxin in heart failure is reduced from 93% to 15%, and bit by bit replaced by 4 additional drug classes. Did this dramatically change heart failure hospitalization and heart failure related mortality?
It's a great question, and it's hard to do a heart failure talk without talking about the controversy of digoxin. And like Simon alluded to, it is kind of going back in time when the traditional therapies for heart failure were digoxin and Lasix, and just at the advent of giving beta blockers and ACE inhibitors. The DIDGE trial, I think, came out in the late 90s, 97. It didn't show a benefit in mortality. It did show an improvement in symptoms, and there was a trend towards decreased hospitalizations. There is a lot of smaller studies, and there's tons of small studies on digoxin. Some will find that it increases your risk of VF. Some will find that it increases your risk of arrhythmias. And there's a lot of emotional prescribing of digoxin too, because people have been doing it for so long, and they have seen benefits of people going on digoxin. There are very prominent heart failure doctors in the country nationally who believe that every heart failure patient should go on 0.0625 milligrams of digoxin due to the positive inotropy of it. And there are very prominent heart failure doctors in Canada who state that that would increase the risk of VF, VT. They might get a shock and their heart failure might worsen. That's kind of the historical, the Gestalt comments about digoxin. The current guidelines recommend that digoxin should be used in patients with atrial fibrillation, that the heart rate's not controlled on maximal tolerated beta blockers, or in the patients that you have on the quadruple therapy that they can tolerate, who are still symptomatic. You can use low-dose digoxin to see if it may provide a benefit. Do I use digoxin? Yes. Given the current data that we have on the quadruple therapy that's being recommended right now, it's fallen down, and I probably do more de-prescribing of digoxin than prescribing it. But if you have someone that's struggling with heart failure and they're not a candidate for advanced therapies, digoxin may be of benefit.
Yeah.
Yeah, thank you, Andrew, for a nice talk. My question relates a little bit around, it was shocking the data you were presenting on the 41% mortality at 1 year, and this is presumably pretty recent in Nova Scotia. The question is around how many of those were on all therapies, and then the second part is, maybe our assessment of sort of advanced therapies for these patients. I get the sense that because therapies are so good at the current time, we tend to obviously favor them, which is correct, but we sometimes miss the subtle findings or subtle things of, well, they're not tolerating certain things, and we miss our window for potentially mechanical device or other advanced. We seem to be doing still not a lot of advanced therapies, while in many other places in the world, the indications are certainly there. You'd expect, 20 to 40 per million, for example, for advanced therapies in a province. And I'm sure you're not doing that, and we're not doing that. So your thoughts on that big picture?
Yeah, it's a great question. I think I'll address the second part first, that 600,000 patients in Canada have a diagnosis of heart failure. So what degree of heart failure, I don't know. Some of it's HFpEF, some of it's HFmEF. But you're right, we have to be missing a large group of patients with decompensated heart failure that are stage D, that could benefit from advanced therapies such as being listed for transplant and getting a transplant, or consideration for destination LVAD if they don't meet criteria for being listed for transplant. We have been trying to address this issue. Dr. Ryda and Dr. Anderson have been actively engaged on it, and before the pandemic hit, we've been talking about doing this, at least starting in Nova Scotia, doing a Nova Scotia roadshow to get out and talk about the amount of patients with heart failure, and at least giving us a call to run the story by us to say, would this patient be of benefit for you to see? Do you think they would be a candidate for transplant or destination LVAD? Destination LVAD has been around for a bit, but I think it's still pretty novel to some places in the periphery that, people are very, very accustomed to knowing the listing criteria for transplant, or at least knowing the gestalt of which patient might benefit from a transplant. I would say that the consideration for being listed or for receiving a destination LVAD, the criteria is much less strict, and we need to be targeting this. And that is a message that we need to get out, that there are people's lives we can save and improve quality of life and longevity of life with a destination LVAD in some of these. And after that long-winded response, I forget the first part of your question.
Yeah, I was just curious on how many of those 41% were actually on, pretty good medical therapy. It shows you.
Yeah, I wish Kim was here. Not everybody. Nobody was on quadruple therapy. Not a good number were on the traditional triple therapy, and that's not abnormal from the trials. Like if you look at Paradigm HF, only 56% of patients were on spironolactone in that trial. And the RAILS trial, I'm going to sound like a broken record to people that have seen me speak before, but the RAILS trial has a number needed to treat of 9 for mortality. So everybody should be leaving hospital on spironolactone if they have a reasonable potassium and a reasonable creatinine. And then I think the ACE inhibitor percentage was around 80% and beta blocker was around 90%. And that's going from my memory of her Grand-Rans talk, so it wasn't great. The trouble is that, I think part of it has to be the multimorbid population in Nova Scotia in general, that not all of these patients can tolerate going home. I think if we take the 3,000-foot view and look down, it's easy for us to say, well, that person should have gone home on spironolactone. But patients with heart failure in Nova Scotia have a whole host of other comorbidities as well. It can be challenging to treat even us in our heart function clinic. There's so many comorbidities that heart failure patients accumulate, some of them the reasons that cause their heart failure, that make it challenging to treat. Yes. That's a kind of a long-winded answer to your question.
Yeah, and I think that's kind of falls into Eddie's question, which is, I'm skipping over Sanders just for a second. At 41% of patients discharged with heart failure die in a year, when is the heart failure team called in? So just to follow up on that, I do think, having looked at this data before for the non-STEMI data in Nova Scotia, when Mike Love shared it across the country, and no one believed it. When you looked at the people that were dying, they were 83 with 11 other medical problems who came in and had a troponin or a CK that was 2 times normal. They were labeled as a non-STEMI. They were dying, and they had coronary disease. But I think that's one of the issues when you look at this. Is it might be nice to look at the data if you took a cut point at an age, everyone hospitalized below the age of something that you would consider reasonable for mechanical support to get to the heart failure team question you're talking about. So, Sandra's question: can you address the hot topic of drug sequencing in the 4 pillar drugs in heart failure with reduced EF?
It's certainly made our jobs harder, Sandra. If you look at the CCS guidelines, it suggests that they need to be on all 4 within 2 to 4 weeks. And they need to be up titrated on all 4 within 3 to 6 months. That's a challenge. I was on a call recently and someone said that, when someone has an ACS, they leave hospital on 5 drugs and it's not a problem. Well, it's a little bit different. When someone has an ACS, they go on aspirin and Plavix, provided there's no bleeding complications, they can tolerate those. They'll go on a statin, and if they don't have any muscle cramps, they'll be able to tolerate that. They may go home on a low dose beta blocker and ACE inhibitor, depending on what their EF is. And they may stay on that chronically if their EF's less than 50, or they may come off of it, in 6 to 8 weeks time if their EF didn't take a hit with their MI. And that's pretty simple. It's not a straightforward comparison, because all of these drugs we're using, like yourself and have issues with, is that a lot of them are potent vasodilators. It depends on what someone's, contextualized heart failure is like. If their EF's 10%, you have to gingerly increase their beta blockers as to not rob them of the cardiac output. Their blood pressure may be 90 and you don't know what dose of ACE inhibitor or sacubitril valsartan to start. You may be taking a very slow approach to up titrating these. Or you might see like a 120 kilogram male who has an EF of 35% that's familial with a blood pressure of 140, and you start 3 of those at once on your first visit, and they're going to be able to tolerate it. And then you might add something else later. So that's the easy answer I'm going to give you. With regards to the silos, and I'm not sure if you're getting at which one to start first and when. It's very, I think that's very nuanced on the patient that you're seeing in front of you. Everybody has opinions about that, and even I change my mind on what I do sometimes. The what are they called? Silos, or the CCS are coming out with like groupings of medications to start at a time and then up titrate. I do see some issues with that. I do like the case that I gave. If your patient has a good blood pressure and you think they're going to be able to tolerate the beta blocker, get them on a low dose of beta blocker, get them on spironolactone. You know, I'm not going to reiterate what I said about the RAILS trial, but spironolactone does not drop your afterload very much. There's a recent trial out in patients with heart failure who go on 25 milligrams of spironolactone or 50 milligrams of spironolactone. It drops their systolic blood pressure by 3.7 millimeters mercury. So it's not going to drop their blood pressure. You just need to monitor the creatinine and potassium. And then start to work on your others. So if they have coverage, or if you think they're going to get an SGLT2 inhibitor, that's fine to start really early on, maybe in 2 weeks, maybe right away. You know, it's not going to alter their potassium or their creatinine. You got to be watching out for if they go hypovolemic, which is very rare in a heart failure patient, hypotension, and just give them some keto sticks to tell them to watch out for euglycemic DKA if they're not feeling well. And then the rest, if you can kind of silo spironolactone and the SGLT2 inhibitor to get them on the basic doses, because you know it's not going to drop their blood pressure too much, then the rest is going back to the basics of titrating their beta blocker and their afterload reduction based on your gestalt and the person in front of you. That's a long-winded answer. Go with your gut. It's nuanced on the person that's in front of you. It's hard to stay up here and give a talk and say, this is the way that you should do it. And it seems like that's what the CCS is going to try to do with these silos and medications to start. We'll see how that goes.
Along the same line, Andrew, questions around how do you know you've got somebody well controlled? Do you follow symptoms or do you follow BNP? What's your advice?
Both. Symptoms always, like every time we see someone in heart function clinic, we're addressing their symptoms for sure. The question of NT-proBNP, we like to do it. So when we have someone referred to the heart function clinic, we like to get so if they have a recent hospitalization, they're going to have an NT-proBNP when they got admitted. We like to do an NT-proBNP the day that they're discharged, because a lot can happen when someone goes home. You might have them nice and euvolemic at Lasix dose of 40, and then they go home and start eating chips and drinking fluid again, and you get their NT-proBNP on the day that they show up for their heart function clinic and their NT-proBNP is doubled. It tells you a lot about how you're going to manage the patient at home. And then with regards to follow-up, so NT-proBNP on date of admission, NT-proBNP on date of discharge, NT-proBNP on date of first visit to the heart function clinic. And after that, it's very subject to the person looking after them. There's no real guidelines on that. A lot of people, you know, some people do it every time they get blood work. That's not our tradition in Halifax. We usually only follow NT-proBNP if something's unexplained. So if their symptoms are getting worse, they're not responding to the treatment as we thought they were. They are losing weight, but their creatinine's going up, and you're wondering if they're progressing more into low output heart failure. More of a when your traditional therapy isn't making sense, let's grab a BNP and compare it to the one that they first came to the heart function clinic with.
Two other questions, and Jaffna's got a very good question there, but I'm going to ask maybe if you can answer that in the chat just as we get to the wrap up. Sandra's raised the question of terminology improved versus recovered in terms of heart failure. And then I'm going to jump down a bit further, which is Amy's talk. How much heart failure follow-up can you do to reach, her words, the heart failure deserts in Nova Scotia? How much can we do it virtually? If we just get weights, blood pressures, heart rates, can we effectively manage? Can we do better? So those will be the last two questions, because we are a little bit over time, but there's lots of good questions. I mean, lots of great questions there.
Yeah, there are. So Sandra, to address your question about improved versus recovered. So recovered, I'm stretching my memory on the true definitions of these. Recovered's the one with the true definition. I think it's an EF greater than 50. improved is anything that gets better than what it was before. So you might have someone with an EF of 10 to 15% and they improve to 35%. Recovered is that your EF returns to normal. And I'm pretty sure that the true definition of that is greater than 50. And in case anybody's wondering whether to take them off of medications, we don't recommend that based on trend HF. And that was a study done in the UK where they started to peel away medications once someone recovered their heart function, and they saw almost immediate increase in their NT-proBNP, and some people had an almost immediate drop in their EF. So based on that, if you have had a low EF in the past and you have recovered, you still have heart failure. You have recovered heart failure, but you still have a diagnosis of heart failure. So you should keep those medications going long term. If there's intolerance to any of them, sometimes I make an agreement that we can stop their spironolactone and continue their ACE inhibitor and beta blocker. But usually everybody's pretty on board if you explain, the gist of that trial and say, based on that, we tried it in the past. Sometimes we did in the past, we don't do it anymore. And with regards to Dr. Hendrick's question, it's really hard. During the first wave of the pandemic, we switched all virtual. We had some, unfortunate admissions and people trying to get into their family doctor in the heart function clinic. And we knew less about that back then, and we are doing more virtual now in the third wave of the pandemic, but it's really hard in there. With no blood pressure machines, with no heart rate measurements, it can be a bit of a challenge to uptitrate medications. We do it nervously. My goal, and something we've talked about is, when you have your first visit to the heart function clinic, you get a blood pressure monitor to go home with. And for your uptitration of medications, we might be able to call, because we can't see, ideally we have uptitration appointments every 4 weeks. I think they're up to 6 to 8 weeks now. If we could send someone home with a blood pressure monitor, we can uptitrate at least the beta blocker and even sometimes the renin-angiotensin aldosterone system inhibitors over the phone. If we gave them a call 2 weeks and say, how are you feeling? What's your blood pressure? We are only going to call you asking those 2 questions. And if they are okay, do this. And then we'll see you in 2 weeks. And that might help. I know certain programs like Edmonton don't even see some of the heart function clinics during the uptitration. And they have a plan of doing it so that if they have any issues, they call, but they just go based by the patient's symptoms. And like we tell our heart failure patients, blood pressure is nothing but a number sometimes, but don't get too focused on low blood pressures. If you're tolerating low blood pressure, it's just less work your heart has to do. And if you're having no symptoms, it means your drugs are working. So if your drugs are working and you're tolerating this scheduled uptitration at home, it's possible, but it's really hard, and people can fall through the cracks, and we've seen that.
So just to clarify, so Amy's question was, if you had weights, blood pressures, and heart rates, how much could you do? So I think you've addressed that.
It's doable, yeah. It's still challenging. We're doing it, but we still have patients show up with JVPs up in their earlobe with the uptitration, and maybe we needed to give them more Lasix as opposed to beta blockers.
Okay.
Sorry.
Jeff, did you have any other comments? Because we're a couple of minutes over here, and I'd like to try and conclude. But
no, I think we should conclude.